Hello, everybody. Welcome to tonight's webinar. This is Introduction to Sprint 60-Day PNS Overview, Evidence, and Clinical Application. We will give it just a minute or two, and then we will get started.
All right, good evening, everyone. Thank you so much for logging on, and welcome to the Pacific Spine and Pain Society's APP webinar. This evening is sponsored by Sprint, and this is an introduction to Sprint's 60-day peripheral nerve stimulation and overview, evidence, and clinical application. And next slide, please. It's with great pleasure that I introduce my program faculty for this evening. The first, we have Victoria Flower. Victoria is waving there. And then we have Teresa or Tracy Malik Searle from Stanford and Jennifer Tarok. Thank you all for being here. Very much looking forward to an amazing webinar. We're going to first kick it off with Victoria. Victoria, before you begin, just give a little blurb about yourself and then please continue with the slides.
Hi, good evening, everyone. I'm Victoria Flower, nurse practitioner. I'm based out of Northern California. I work with Dr. Samir Sheth. We are part of a hospital-based kind of system, and so we have a moderate-sized practice. It's us, me and two physicians. So I'll go ahead and get started. I want to thank you all for being here tonight. I know that you have a lot going on, and so I appreciate the time that you've taken to be here with us tonight. For my portion, we'll kind of start with a short discussion about the device. We'll talk about how it works, and then we'll dive into some of the clinical evidence and safety data regarding this device. So for those who are unfamiliar with this device, it's a 60-day short-term PNS therapy. And when I say short-term, meaning that it's placed for a short term, but your relief can last a bit longer. What's nice about this device is it's minimally invasive, doesn't require any incisions. So that's one of the wonderful things about it. Next slide, please. Now, this device and its introduction and just PNS in general has really changed how our practice has dealt with patients with chronic pain. In the past, we would have put something like PNS further down the care or treatment continuum. And after this device came out, we started moving it forward towards the center of the continuum, and sometimes even before treatments like radiofrequency ablation. For some younger patients, this might be more beneficial than, say, an ablation, and there is some evidence to support that some patients actually prefer short-term peripheral nerve stimulation over radiofrequency ablation. And in particular, if you have younger patients who are maybe in their 30s and 40s, where you're worried about multifidus muscle atrophy and low back pain related to radiofrequency ablation, then you might consider this as an option. But sometimes even for things like patients who have knee pain and are thinking about knee replacement, but not quite ready for knee replacement, this is a really great option to consider. So overall, this has really kind of changed where we look at neuromodulation and specifically peripheral nerve stimulation in the treatment continuum. Next slide, please. So what makes Sprint PNS beneficial, and why would you choose this option? So one of the things that is important to note is that is the least invasive PNS option available. So as I said earlier, there's no incision. So they use a 17 gauge needle to insert the lead. And this lead is small. You can see in the right bottom hand corner of your screen is the picture of the lead. It's 300 microns, so it's a small lead. And the design of the coil is actually, or the design of the lead is in a coil. And that actually helps reduce migration because that design of the coil makes it different than any other SCS or PNS lead out there. And that coil allows tissue ingrowth. And instead of using things like anchors and things like that to hold the lead down, this allows the tissue to hold and anchor that lead down. So you don't need to cut the patient open to add anchors or anything like that. The device itself is designed to stay in place. And the second thing to think about too is infection risk. So the design of the lead does help reduce the rates of infection as well. So these patients have these really tiny leads that are placed, and using about a 17 gauge needle, that adds to one of the safety factors. The second thing is that these leads don't have to sit right on top of the nerve. They have to just be within a centimeter of the nerve to be able to stimulate it. So that does make it a lot easier as well. For some patients, because this is so simple and minimally invasive, some patients who are hesitant about moving forward with a different device, maybe something that's more permanent, who are worried about an incision, worried about something permanently implanted in their body, or maybe their health status doesn't warrant heavier sedation, this is a nice option to choose for all of those reasons, and that does help with the safety profile of the device. There's also single and dual lead configuration. So if you wanted to, let's say for low back pain, you can certainly target a lumbar medial branch nerve, and you could target a cluneal nerve if you had unilateral low back pain you wanted to target. So there are ways you can use this device to target more than one nerve at a time to get a bigger area. Next slide, please. So,
I'm so
um,
sorry about that. Yeah,
sorry.
I apologize. I was like I was worried that like it was like the pandemic all over again and someone's going to be like, "Are you on Zoom? What's going on?" Okay. So thank you for that brief overview. That was awesome, Victoria. So with this, how are you introducing your patients to Sprint, and what are the key points you make sure to cover? I would like, if you don't mind, Victoria and Tracy to both give us some responses to this.
Tracy, you want to go first?
Sure. So when I'm thinking about a sprint for a patient, I really like to first think about and then share with the patient all of the other options, all of the other treatments that we've gone through over the course of their journey with me, in brief. And then I start to talk about how Sprint will work in a way that's different, right, from anything that they've tried in the past. And even if they've done things, say, like physical therapy or occupational therapy or behavioral management, cognitive behavioral therapy, that they can still continue to use all those skills that they have achieved and go through those exercises, and that Sprint might add something in addition, right? So it's really a multimodal part of their treatment plan. Um, I also talk to the patients about setting expectations and how, explain to them, if they're interested, some of the data behind satisfaction and efficacy. But at the end of the day, it's really about what they want to achieve, right? And so that's how I move into my explanation with. I talk to them about the fact that it works at local nerve injury or damage. There's no systemic side effects to it, and that there's patient care needed, right? So, again, setting expectations in terms of what their responsibilities are going to be.
I love that. Victoria, before you answer, can you focus a little bit more on how you address patients' concerns regarding like the long term, right? So you said this, in your talk briefly, that we're talking about something that's just for 60 days and something specifically that's beneficial, particularly in patients who are concerned about like a permanent implant. So similarly, how do you convey like the efficacy beyond the time of just the 60 days of treatment so that like you're managing expectations like Tracy said?
Yeah, so I do, so kind of like Tracy, I do give patients options and I do educate them on that. There is a possibility that the data does support that you get relief up to 14 months. I've had patients go out longer, up to 2 years, but I also do tell patients, the reality with anything we do is that there's no guarantee that it's going to work. And so if there's a chance that it does work, let's say short term, we can always proceed with permanent. And if it does work for a short period of time, but you do get relief, say for 6 months, a year or so, we could decide, depending on your health plan, whether or not we want to repeat that, whether or not we want to do a permanent implant, whether or not we want to try something different like radio frequency ablation. So depending on the nerve target and the patient's comfort with some of the other alternatives to it, that's kind of usually what I will discuss with them. And a lot of times what happens too, they always want to know, well, what happens if this doesn't work?
Mhm.
And then so you kind of sometimes are prepared for that. And sometimes I tell them, I don't know.
Yeah.
Because sometimes I tell them, I haven't thought that far ahead. I don't know. And sometimes I'm like, well, these are the options. And we certainly can think about that. Let's stay positive. And let's kind of start with this. Expect 3 weeks or so before we get any relief. And I'll kind of explain that in a little bit also. But I kind of use a mix of those talking points.
Great. Well, with that, let's
And
take
I think that's a really,
well, just in
sorry.
this time, Tracy, I'm gonna say let's get to the next slide so we can keep moving on. And is this back to you, Victoria?
Yes, it's me. Mhm.
Great.
Yeah, so in general, when we look across about 145 publications, we find that those participants, greater than 70% of them, are experiencing at least 50% relief. Next slide, please. And so the reason for that is this mechanism of action. Now, I am going to oversimplify this. I recognize that I'm going to be oversimplifying this. So to any neuroscientists or anyone else in the room who are like, this is like not this simple, I understand that. But this is the kind of talk track I give my patients. So this is exactly what I tell them. This is exactly how I explain to them how this works. So I tell them basically how we feel pain, how we experience pain and chronic pain or any level of pain. It's all through these electrical signals that get delivered to our spinal cord and then go up to our brain. Our brain processes it, magic happens, we feel pain. And so what happens when we're using a stimulator, as you can see in the center picture, what happens during that stimulator when it's working is it delivers a different signal, a signal of our choosing, whatever that may be. And so once that signal gets delivered, it interrupts those pain signals that are getting to your spinal cord and to your brain. And so what happens is you're getting a mix. You're getting a mix of that chronic pain signal and a mix of that healthy signal. And the hope is that you're retraining the brain or rebalancing the signals that you're getting. So instead of it's chronic pain all the time, you're getting some of that healthy signal being delivered from the stimulator to rebalance. And hopefully that's how you'll get sustained pain relief. Next slide, please. Now, as I mentioned, there's a ton of evidence around this, and obviously we want to be able to give our patients an evidence-based therapy. As I mentioned, across 145 peer-reviewed publications, there has been evidence to support the benefit of peripheral nerve stimulation. The most common nerve targets we're seeing, shoulder, lower extremity, neuropathic, low back, those are probably the most common ones that we're seeing, or at least we're treating in our practice. Next slide, please. Now, RCTs are really great, and studies are a really great way for us to understand how beneficial a device can be. When we look at a collection of these studies, 16, and we look at these 16 different prospective clinical studies with 10 unique cohorts, we look at these different nerve targets, shoulder, back, neuropathic, and what we're seeing is that there is a pattern. The majority of these are very similar. They're getting relief up to 14 months. And you can see with the pattern with their how they're overlying, looking at the different studies, we're showing the same outcomes and it can be reproducible up to 14 months across a bunch of different nerve targets. Next slide, please. And in clinical trials, obviously, those patients are like the perfect candidate for that, right? And the real world doesn't always mimic the world of clinical trials. Real world is messier. There's a lot more going on. And so what we see in greater than about 6,000 patients, they looked at these records, anonymized records, over 3 years, August 2019 to 2022. And what they found was the same thing. These mimicked those clinical studies. And so what we're seeing is across multiple different nerve targets, we're seeing that they're getting approximately 70% relief. If you're looking at the chart on the right, you can see overall across all these different nerve targets, you're seeing a similarity between that and the clinical studies, which is important to appreciate. Next slide, please.
Great job. Thank you so much. Look how well timed that was this time. I'm so proud of myself. All right, Victoria and now Jennifer. I'd like you guys to each think about one case. And I know, Victoria, you probably could think of a lot. And Jennifer, you probably could think of a lot too. But I want you both in your mind's eye to think of the one case that, like, if you were going to try and tell a patient about this, like, this is the thing that sealed the deal for you, that was such a dramatic improvement for this patient. So Victoria, why don't you start with one?
Someone that I can remember only because he came back in recently was an older gentleman, probably in his 70s, and he had this post-stroke leg pain. And we targeted a nerve, I believe it was femoral nerve, and it improved his pain so much, and he was able to ambulate more. The downside is he started to develop pain in another spot in his leg, but he came back in asking for this device to be able to treat this other pain in his leg. And so to me, I think that really demonstrates his faith in the device and the therapy itself and how much it really changed for him and his family. His wife was like, I still can't believe that, he was able to do so much. Now that he's got this other pain, they're hoping that he can get back up to do things. For a long time before we implanted the device, he was in a wheelchair because he just couldn't ambulate very well. He wasn't very mobile. So the hope is that once we get this second therapy going, that he'll be able to be more active and more mobile, to do some more of his physical therapy. So my hope is that if a patient heard that story, they would appreciate what a big difference it made for this patient's life.
I love that. Jennifer, what about you? Talk about a case that really resonates with you, that when you're talking about this for your patients, this is like the one that you're like, let me tell you a story, girl.
Oh, perfect story. So we had a 69-year-old female who had had constant right-sided occipital neuralgia. She had been seen by many physicians, been to the Mayo Clinic, and everybody kind of had told her the same thing. So she was being managed on pregabalin, nasal ketamine, and oxycodone. Still had an NDI of 64%, and her pain was still rated a 9 out of 10 on a daily basis, even though we were doing all we could, and all the blocks and all the things that we had tried had never been successful for her. She came in and Dr. Jameson placed a right C3 peripheral stimulator Sprint, and she got 2 years of pain relief, and life-changing for her.
Wow, that is life-changing for anyone, 2 years of relief. So with that, let's move on to the next slide. And then who is this, you, Victoria, still?
Yep, still me. So a common question that we get is why 60 days? So there's some benefits to utilizing a 60-day therapy. One of them can be identifying patients who maybe are delayed responders, or identifying patients who might be non-responders before you consider a permanent implant. So this may help you include or exclude patients for permanent implants, potentially. Next slide. So I want to draw your attention to this graph. We're going to start at the bottom half of the graph. So at the bottom half of the graph, we'll start with the early non-responders. So we can see with the early non-responders, there's about 30% of those, so about a third of the patients you'll see in the real world, and this is looking at over 700 participants. So in the real world, we're looking at about 30%, a third of your patients that you're considering or doing a PNS trial on, they're going to be early non-responders, meaning they're going to start off they're not going to do well, and they're not going to do well the whole time. They're not going to get any relief the whole time. The second cohort we'll look at is right above them, the delayed non-responders, about 17 or 7%. And so they start getting a good response, but then it kind of peters out, and then it kind of drifts, and then they end up not doing well by the end of the therapy. So then we'll go kind of transition to the top part of the chart. What we'll see in the top part of the chart is the early responder. So what we'll see is 80 or those folks are getting 80% relief plus or minus in the beginning, and then it's sustained, which is great. So we know those folks are going to do well. Now this other one, which is the delayed responder, so right below that in the green dotted line, you're going to see about a third of your patients potentially will start off not doing well, but around week 3, they'll pick up and they'll experience relief. So what that kind of tells us is your typical trial period of 7 to 10 days or so may not be enough time for a third of some of the patients that we're trialing. So a third of our PNS patients that we're trialing, they may not notice a difference until 3 weeks, a third of them. And so potentially what we might be doing is missing a whole group of patients, 30% of those patients we're trialing. We might miss that group, and that group might miss the opportunity to get relief from a PNS option. And so this kind of tells us, well, maybe we need to give them a bit more time. Maybe they need a little bit more time with the device to be able to see whether or not they do well. And I bet these 30% of these patients that we're missing would really like to have a therapy that could benefit them. So that's just something to think about when you're looking at some of your patients and deciding which device to choose. Next slide, please. Now, when we look at things and kind of like when we're thinking about that treatment continuum or that clinical pathway, there's a few different things you can consider and a few different things you can decide. So if you're getting relief and it's sustained, you have a few options. You can continue doing that. You can move forward to a permanent implant, or you can decide to, do the repeat sprint. So you could do any of those things. You could just monitor as well. If you don't get any relief, then obviously you can consider other things, other therapies. If you get relief and it's not sustained, so you get relief maybe for a short period, maybe it's only during the 60 days, then what you can do potentially is you can consider a permanent implant. So there are a few different pathways you can take depending on how a patient does with this device. Next slide, please. Now, the other thing that we talked about, so we kind of talked about wanting to kind of go into the clinical evidence. We wanted to make sure there was support for a therapy that we choose for our patients. The other thing that I think is important to kind of point out is the safety profile. So what is interesting to consider for this is that any event that there were mostly non-serious events. I want to draw your attention to the right side of this table. On the right side of this table where it says published clinical studies, the top thing that was reported was skin irritation. And at the very bottom were infections, 0.3%. So that's in the published clinical studies. If you move over to the other side of the chart under commercial use, the top issue is skin irritation. And then right below that is confirmed or suspected infection. So I have thoughts and feelings about this. So in the last 5 years that we've been using this device, I have maybe had 1 to 2 infections that were unconfirmed. They were suspected, they were unconfirmed infections. We just treated it as such. But the majority of the time, what I do think is happening is that we're actually getting more skin irritation than anything else. And for the patients that report to you that they have skin allergies, adhesive allergies, there are a couple of different things you can do ahead of time and to kind of prepare for that. So what we do in our clinic is we actually do a little patch test with a bunch of the different dressings. And we're fortunate to have a bunch of different options. Our team is really great with that. Our SPR support team is really great with that as well. And we try a whole bunch of combination of things to kind of understand how much these patients will react. And the majority of the time, we're able to find something that works. So I wouldn't be put off by any patient that has concerns about adhesive allergies or skin irritation. I think that is something you could potentially work through. It takes some creativity, but it certainly is something you can work through. And I think that's something that you can work with your team on because there are a lot of interesting tactics you can do to prevent anything serious. Most patients tolerate this fairly well. I have a small handful that don't, and we work around that. Next slide, please.
Great. That was an awesome summary. Thank you so much. And I think it's really important, Victoria, that you talked about like what are your options when you're dealing with patients with skin sensitivity. A lot of times when we're dealing with skin sensitivity in general, like one of the easiest things if you don't have testing options to start with might be even using like a Flonase, like and having the patient spray it topically on their skin. And that's because it's a steroid, and if it allows it to dry, that can help. And we use that a lot of times with like medications and stuff like that. But let's ask this one for Jennifer and Tracy. So, Jennifer, um, let's say you have a patient who's been seeing you and Dr. Jameson, and they are a little hesitant about anything in them. Like, what do you tell a patient specifically with PNS? And I think Victoria did a really great job of talking about, this is done through a needle, there's no incision. So talk to me a little bit about like, give me like a 30-second talk track of how you present this.
So I think the biggest thing is obviously we've talked about this already, is that it's temporary. So most people can kind of wrap their minds around, that I'm going to commit to 60 days, and most people can definitely handle that. But I'm really honest with my patients, and I think the thing that helps a lot of them is I'm honest and say that when my cervical arthritis is to the point where I need treatment, this is going to be what I choose. And I already know that, and I don't want to accelerate the whole arthritis thing, but I know how I'm treating it, so I'm ready.
I love that. And thank you for being quick with that. Tracy, same when you were talking with patients at Stanford, talk to me like what are the things that you reiterate? Obviously we don't need to replay Victoria's whole great talk track, but like what are some other pearls that you like to pass on to people so that they can feel confident with this?
I start by telling patients that obviously, this is not a treatment for everyone, right? Not 100% of people are going to be responsive to it. But I share with them the clinical trials that show that greater than 70% of people have had some response to this treatment. And so it's, again, like Jennifer said, it's temporary. We're not looking at putting a permanent implant in you. A lot of patients, even when they hear about peripheral nerve stimulator or temporary, they think it's something they're going to have to live with forever. The stigma of the procedure itself can be very off-putting. So sometimes I'll share with them the videos that are available so they can kind of watch the process through. And that usually will get most buy-in of patients, and if they're 100% against it, then we move on to something else.
Really great. All right. Well, next slide. And then I'm guessing Victoria's done. Who takes over now? Jennifer. Perfect. Jennifer. So Jennifer, briefly give us a little bit of history. I know you mentioned Dr. Jameson, but talk about a little bit where your practice is and how it's set up.
Yeah. So Jennifer Torak, I'm a nurse practitioner. I've been working with Dr. Jessica Jameson at Axis Spine Center now for about 9 years. We're located in Coeur d'Alene, Idaho. We're in a comprehensive spine clinic. So we have a surgical spine team and our interventional pain team, and we work together to care for our patients. So today I get to actually talk about pre-procedure, procedure, and post-procedure kind of best practices. So as an advanced practice provider, I'm obviously not going to be the one who's doing the actual procedure, but I may be the only person who has communication with the patient prior to them actually having a temporary peripheral nerve stimulator inserted and for use. So it's really important that we understand at least what the patient is going to be going through and to prepare them so that they make educated decisions and kind of have that set expectation of how things are going to go. I know my physician relies on me to be careful to map the painful regions and to make sure that we're, targeting specific nerves and giving her as much information as I can, for her to help, make this decision. So I may set the patient up, but then she'll make final decision sometimes, right like the week before our procedure. So there's we can do 1 to 2 leads, and we can do different types of frequency. So you also need to consider whether you're going to use fluoroscopy or ultrasound for the lead placement. So again, setting that expectation so that the patient knows that we're going to be checking to make sure that we put the lead in the best possible place, I think is also helpful. Next slide, please. So this is just a step-by-step. Again, this is super helpful if you're trying to explain something to a patient that you're not actually doing yourself, but obviously procedure prep we do with any procedure. So we're going to make sure we have a sterile environment. We'll get all of our things ready. We're going to use our either fluoroscopy or ultrasound to identify where that nerve is. We're going to insert a test probe, and that test probe is going to give us some information. So next slide, please. So that information is telling us that we are in the general area of where we want to be. So we place the micro lead and we're going to do testing to make sure that we're getting the response that we want. So the patient may be asked, are you feeling buzzing, tingling? Are you feeling muscle contraction, or can we see the actual muscle contraction? Once we feel like we're in the right place, we're going to deploy the final lead and we're going to secure it down. So next slide, please. But before we secure it, we have the option of moving that lead a little, in further, out further if we need to. So we do have a little bit of play to make sure that we get it in the right location for the patient. So then again, we're securing the lead. And this is actually secured, I think Victoria had mentioned this, without actual anchors and really no incisions. So we have this device that then lays on the skin. And then we're going to put a special bandage over the top that's going to allow for the external generator to be placed. We'll start the program and start working with the stimulation. We're going to provide the patient with discharge instructions, and Sprint does a great job. There's actually, and you'll see it, I think, in the next slide. Please, they'll have a bandage instruction sheet, because most of these lead placements are going to need some sort of spouse support, caregiver support, because some of them are definitely hard to reach, and you don't want to dislodge the lead. So you're going to need someone who can actually, get that moved safely, because we're going to be changing the dressings. But they have great educational pieces, and then again, a good discharge instruction sheet, so the patient will leave with the information that they need. Best practices for the implant, we're just going to make sure that the lead is close to the nerve, but not touching it. Hopefully, we're going to try to get the stimulation to cover at least 80% to get the best pain relief for the patients. The patients are going to potentially tell you that there's tingling, buzzing, pulsing, vibrating pressure. That means that the device is doing what it's supposed to do. So we're trying to confuse the brain, change the signal. Those are the kind of things that we're definitely after. If anything is uncomfortable, sometimes we have to adjust the lead accordingly. But again, we're looking for that 80% coverage of the area that is most painful. Next slide, please. So here's on the right-hand side of the screen, you'll see the handout that's the bandage guidelines. So very detailed on how it's changed. So caregivers can definitely be helpful, or patients if they're changing them themselves. We definitely want to make sure we use good, hand washing and make sure that we have everything we need before we get started. We're going to keep the site covered and also make sure we're taking off the external generator before we get into the shower. Showering's fine. We're definitely not going to want to be submerging ourselves in a hot tub or a swimming pool or in a lake until that lead is removed and the puncture site is well healed. You're going to change the bandage 1 to 2 times per week, but more often if it's soiled or coming loose. And again, we already talked about caregiver assistance may be needed. We're going to limit activity depending on the location. Usually just 1 week is just to allow that lead to kind of get anchored into the tissues. But after that, we should be able to have pretty normal activity. Next slide, please. All right, so 60 days post-treatment. So again, we may be seeing the patients after treatment as well. So making sure that the patients are getting strong, comfortable sensations, making sure they're not getting painful stimulation. If that's the case, we can make some adjustments. There's different types of stimulation, sensory and motor, that will determine how many hours a day they're wearing their actual generator. But a lot of patients will take it off at night to sleep and then shower and then put it back on. But some patients get such great relief. They're like, can I just leave it on full time? Just take it off before you shower. We're going to use the treatment as prescribed, but we're going to also make sure that the patients know that it might be 5 full weeks before they actually get relief. And in patients who get relief right away, we definitely want to remind them that they need to be using the device for the full 60 days so they get that long-term relief that they're looking for. Next slide, please.
Sorry, here I am. How kindly I was trying to be really good. All right, this one's for Jennifer and Victoria. How do you set appropriate expectations for the patients regarding pain relief timelines? So we talked a little bit about sometimes it can kick in a little slower, so is there a timeline that you tell them, like if you're not getting pain relief by this time, maybe you're a non-responder, or like, is it, you might not get pain relief till the very end? Like, how do you preface this conversation if, like, let's say they're 3-4 weeks in and they're not seeing any changes? What do you talk to them about?
I'll go first. Is that okay, Jennifer? Okay. So yeah, so I'll let them know ahead of time that potentially it could be 3 weeks or so before they experience anything. And I will tell them, you went through all the trouble to get this device in. Let's stick it out for the full 60 days. If you really get nothing by the end, then we can say, all right, we tried our best. That's usually how I approach it, but I let them know ahead of time. Don't expect much for 3 weeks. Give it at least 3 weeks. And then if you don't, let's just kind of stick it out. You might get some more relief later on. But really, if they are like, really stuck on wanting to get it out, then I will bring them back in and I will remove it and I will move on to something else. But that's kind of how I approach it. What about you, Jennifer?
Yes, I think we kind of touched on that, up to 5 weeks before some patients will get, relief, and then some like right away. And then of course we're like, keep using it, don't quit if you're not going to make pain come back earlier. But I try to remind patients that we all experience pain differently and pain relief comes differently to each of us. So I think it's just kind of guiding them and being with them. The other thing we can do is try to change the stimulation, see if we can wear it longer during the day or turn it up, turn it down, troubleshoot with them because maybe they're just not using it to its full advantage. So I would definitely want to troubleshoot with them first and just, make sure that the lead looks like it's maintained its position. So being mindful that lead migration can happen if they stop getting relief too. So if they were getting good relief and then they stopped, I think getting them assessed and making sure that that lead looks great and that they're bandaging it correctly and that they're wearing the external generator correctly. I mean, some of our patients, it's hard to see and reach and stuff. And so maybe just getting them in and taking a look at what they're doing would be helpful. So.
I agree.
Thank you so much. Well, let's move on to the next slide then. Tracy, it's all you.
Oh, thank you. So I'm Tracy Malik Searle. I'm a nurse practitioner in the Division of Pain Medicine at Stanford in California, and very excited to be here and talk to you about patient selection. You've heard earlier on in this slide deck that Sprint can be used in a variety of different pain conditions. There's the opportunity to target multiple different nerves from post-amputation pain to occipital neuralgia, which Jennifer shared with you, low back pain, cervicalgia, even complex regional pain syndrome. So we have a lot of different nerve targets that we have available and a lot of different pain conditions that we have opportunity to treat. But ultimately, it's using your best judgment when to use Sprint PNS. Next slide, please. Some of the general overview considerations that you want to think about, right? Not all of these are hard and steadfast, but they're a good general rule of thumb in terms of who is going to benefit and who may not be a candidate for a Sprint device. So you want to make sure for sure that you have a healthy nerve target, right? The ability to stimulate proximally or close to the injury or the nerve region, the region of pain. Preferably little or no history of poorly managed psychological problems, such as poorly managed depression, poorly managed bipolar disorder, outrageous pain catastrophizing. These might be patients that just aren't going to benefit from a vast majority of things that you have to offer them. Again, preferably no opiate use or low opiate use. Definitely, you don't want to consider a patient that has a full-blown opiate use disorder, right? There's other issues there. If you have a patient that is taking lower, maybe not every day, morphine milliequivalents, then, it's again a decision. It's a clinical decision that you make. No history of recurrent skin infections, particularly around the area that you're thinking about implanting. That patient has a caregiver or somebody in the home that can help with cleaning, charging, making sure that everything is just operating appropriately. Again, and being on the lookout for skin infections. We have here no history of allergy to bandages or skin, but you've also heard earlier in the presentation that there's ways to kind of manipulate that around. If you put an adhesive on somebody that's not typically allergic to Band-Aids or to adhesives, you're going to have some redness. And so it's a really nice idea to figure out a way that you can cope with that if it does occur. Next slide, please. Some additional patient selection criteria, again, preferably a low or a normal body mass index, preferably 30 or below. And this really is just when you're looking at the ability to target that nerve and insert that lead, that you're able to get to the lead. You're not going through a lot of subcutaneous fat. Preferably no confounding pain conditions, particularly pain that might mimic the nerve pain that you're trying to go after. Prior surgeries that can alter the anatomy, it depends upon the clinician putting in the device, but often this can impede lead placement or use of the device. No recent anesthetic injections. So again, you wouldn't want to numb up that nerve and then try and get stimulation of the target nerve that you're trying to treat. No ablation of the target nerve. Again, that's not 100% a contraindication, but if you do have an ablation and the nerve is no longer active, that could definitely not be a situation where you want to implant a PNS device. And then no secondary gain issues. Again, it goes along with the opiate use disorder. Patients that are in a situation where they're de-incentivized to get better might be a relative contraindication. Next slide, please. It's probably one of my favorite studies that I've ever had an opportunity to talk about. So this was published by Dr. Statz and colleagues in 2021, and it was a market research survey looking at almost 350 patients. Average age was 34 to 75, so big age range. That had activity limiting moderate to severe axial back pain for greater than 6 months in duration. And of this patient cohort, they were given 2 options of treatment. Actually, they were given 3 options of treatment, one being not doing anything. But the 2 that they were really interested in is patients that were interested in a radiofrequency ablation, multifocus denervation, or a 60-day PNS with the potential that they might have lead fracture. So patients were given the explanation of the device, what the efficacy treatment outcomes were projected to be, but then also the side effect profile. And patients overwhelmingly preferred PNS as a motor sparing option. So you see the results there in the bar graph. Almost 46% of patients said that they wanted the 60-day PNS when they understood what the benefits and the side effects were, versus 28% of patients that wanted the RFA. Obviously, patient preference should be unbiased, right? Patients should be given the full gamut of the options that are available to them, and they have a clear idea when they move into their decision making. Next slide, please. All right. So we're getting into the end of the slide deck here. So what I just want to bring it all together is rethinking pain strategies, right? Understanding that there are multiple treatment options that we have for patients with peripheral and centralized nerve pain. And it's having enough of an understanding that you can make an educated decision as a clinician and then be able to explain that to your patient and decide what is the best treatment option. So Sprint PNS offers a treatment that's non-opiate, non-ablative, easily reversed or repeated if you need to, and it may reduce the need for permanent implantation. Studies with Sprint PNS and chronic low back pain have demonstrated that most patients experience a clinically meaningful relief. 60-day treatment can produce sustained pain relief, and consistent pain relief has been observed across many different painful areas, including low back pain, headache, cervicalgia. Next slide, please.
Tracy, that was amazing. Thank you so much. And let me ask you, before we finish up with some of the participant questions, Victoria and Tracy, give me a little bit of some of the commonly asked questions that you get from patients beyond, is it going to work?
That's number one. Is it going to work? How long is it going to work? What are the side effects? Can it be repeated? Will I need it to be repeated? I think many patients think that this is a stepping stone to a permanent implantation. And so there's a lot of re-education because I think a lot of our patients are familiar with what it means to have a device implanted. And this is a whole new paradigm of a temporary device that can give sustainable, long-lasting benefit. So those are some of the questions that I get most commonly.
One of the things that comes up for me, because on the little lead connector, which is the thing that the lead goes through, there's a little circle on it that says no MRI. And so I get patients sometimes ask me, well, what happens if I need an MRI emergently? One is we can easily pull it out and they can have an MRI. And two, I would say, well, if you need an MRI and it's something that's non-urgent that can wait, you preserve your MRI status at the end of therapy. So once we explant that lead, your MRI conditionality goes back to what it was essentially before you get the device implanted. So sometimes that comes up for some patients where, you know, if they have something that needs surveillance, if they have a history of cancer or anything like that, that needs to be monitored with serial imaging, that is something that comes up. And I tell them, like, one of the benefits of this device is that while it's in, yes, it's possible that you can not have an MRI, but afterwards, your ability to have an MRI returns. And I did have one patient that broke their hip and they needed an MRI. No big deal. We pulled the lead out. We were able to have that done. They were able to get their MRI at the hospital and then they were able to get treated. So if that does come up, it's not anything that's really like show stopping. It's certainly at that point in time, you can work around it and worry about therapy later.
Love it. Very great. Okay, I think there's an ending slide. Next slide. So there are some digital materials available. As you can see, you can scan this QR code and it's going to take you to access all the latest educational materials, understand specific targets. In fact, we had a question that was actually on targets. The question was a little more focused, and I'm sure each of you might have an answer. So if you're treating, like, for example, neuropathic leg pain with this, where exactly are you placing the peripheral nerve system? Now, I think that personally, you need to distinguish, like, are you treating neuropathic pain like peripheral neuropathy, or you're treating like a specific mononeuropathy or a nerve injury? So Tracy, why don't you start with that answer? How, because I think this came up when you were talking, or maybe Victoria. So why don't you start and we'll each have a turn listening to this.
Sure. So it can be quite complicated, right? And it's really a clinical decision. I think the main objective is to be able to find a target nerve, right? So preferably mononeuropathy, but you know, it can be a little bit difficult. Sometimes, if it looks like there is a target nerve, going ahead and trying the PNS, seeing how the patients do, see if there is another pain generator in that general location. And again, one of the soft patient criteria talk about not having other extraneous nerve injuries or central presentation that could interfere with your decision making about efficacy with the device. So it's not always really clean, but because of some of the unknowns about how a peripheral nerve stimulator works, you may get, even if you're targeting a mononeuropathy, duplicate pain relief at surrounding nerves because it's happening, something's happening in that general tissue space.
Yeah, I think for me, if I were to like call out specific targets, I think just kind of like what's been said, it depends on your area of pain. So, we have patients who continue to have pain, let's say after they've had like a hernia repair surgery. So that might be ilioinguinal. If it's foot pain, we might consider, depending on, the part of the foot, we might consider popliteal sciatic or, tibial, sural. Those are other nerve targets you can consider. Sciatic you can consider. So it really depends on what type of neuropathic pain and where it is. Generally speaking, I usually tell people if you can identify it by injection, if you're going to be able to inject that nerve, you usually can use the Sprint device for that nerve. So that's something to think about is if you could target it with injection, you could probably, and I say probably, not definitely, but probably get to it with a peripheral nerve stimulator.
Yeah,
And
I think. Oh, go
And
ahead, Tracy.
sometimes that can also be complicated too, right? Because when you do nerve blocks, you get a field block. And so, but I love how you talked about, kind of the specific areas that could all account for nerve pain in the foot and the leg.
I think we try to be just as specific as possible, right? So we're going to have better outcomes if we really can identify that target and map the pain. But again, it's different for each provider too. So not all providers kind of approach, or all physicians approach, nerves, the same. I think their comfort level changes too. So I think working closely with your interventional pain physician is probably the best way when you've got something that's a little bit more complex like that.
I really, really love those answers, guys. It's funny because initially this type of therapy came to market for patients with post-stroke shoulder pain, right? And so, I don't want you to, to dismiss that there's going to be patients who have strokes who might benefit from these kinds of therapies too. So things to think about. But again, I think all of the things that you guys talked about, where it's like finding a specific nerve to target, right? And then realistically, can we get it there? Like you can inject near pudendal, but like you don't want to necessarily, maybe this might not be your first choice for pudendal, right? Because there's a wire that's going to be coming out of an area that might be precarious. It needs to have like something stuck on it constantly and they have to sit on it, et cetera. So thinking about your target is really important, and thinking about like, can you use this long term? We have another question. Do you ever redose or re-implant patients who have done Sprint before? And if so, what are those outcomes for them? So the question, I guess, is something that we talked about a little bit earlier, where I think someone said, do you ever, retreat patients? So what's your threshold for retreating, and how do you decide? What do they need to have a percent benefit that you set as a threshold? So why don't you start with this, Jennifer, and then you guys can each answer it.
Yeah. So I think one thing we have to ask ourselves first is whether or not insurance will cover it. Unfortunately, insurance gets to decide a lot of what our patients get and do not get, much to our dismay. So we recommend if a patient gets significant relief, I don't know that we necessarily percentage, but I guess if I had to put one, I would say a minimum of 50%. At least during the treatment period of 60 days. We may even try to retreat after that 60 days. But if I have a patient who had 2 years of pain relief, like my lady I presented before, we really wanted her to reimplant, but she chose permanent. So it depends on, I think, kind of the situation for sure. But if a patient is actually wanting to do that, we'll try to work with the insurance to see if we can't get a retreatment for sure, if the patient finds it, beneficial and we can justify that.
I agree. I mean, I think as this continues to be more mainstream, I look at it like some of those other treatments that we might do on an annual basis or sometimes even every 6 months. So being cognizant of insurance and the payer for sure. But it's such a, minimally invasive amazing treatment that I don't think that they're, as long as patients and, and your threshold of relief, I love 50%. Sometimes it's, less than 50%, but the patient's reporting that they're able to be more functional and do, additional things. So I don't have any hard and steadfast rule about not reimplanting, but I really wouldn't want to do it any more frequently than every 6 months.
So,
And you also want to make sure that, they're not having a new pathology too, right? So is there something else that's going on? So you wouldn't want to get into a habit of just reimplanting, and missing maybe something else that might be surgically worthy.
great answer. And Victoria, maybe you can touch on this too. So like, what is the duration of efficacy you want to see from a patient before you might consider redosing?
So meaning like
Like,
changing.
I mean, did they only have relief during the 60 days, or did they have sustained relief for another 60 days after it, or 6 months? Like, to Tracy's point, if this is something that we want to redose or retreat, like we do lumbar radiofrequency or genicular ablations or things like that, I think payers are gonna, people want to know what is the time that this actually was efficacious for the patient, right? Before we are allowed to do it. We have all of those limits for sacral iliac joint injections, everything. So what's your limit? Because I'm guessing there's not really a hard fast because all of the insurances are different, right? So
Yeah, so for me anyway, I feel like, or at least in our practice, if they're only getting relief while they're in therapy, meaning while the device is in, I'll usually recommend a permanent at that point. If they get sustained relief beyond 6 months, then typically I'll say, hey, that's and 50, we use 50% as well, 50% relief at least for 6 months, then I'll consider repeating it. And part of that is because Medicare has a 4 lead per 365-day rule. So you are only allotted, at least with Medicare, those leads anyway. So if we're going any shorter than that, you can't get more. So at that point in time, I would usually steer them towards permanent. But if they're able to get at least 6 months, and we have used 2 leads, we have 2 leads that we could potentially use within that 365 days, then I would consider repeating it if they were really uneasy about a permanent implant.
great answer. Sorry, I'm eating some gushers. Tracy, Jennifer, and Victoria, you guys were amazing tonight. Thank you so much for sharing all of this. I think there's one last slide for additional questions, but yeah, sorry, I knew that was there. But what I was going to say is we don't have any additional questions in the audience, but before we sign off, give me each one pearl that you want everyone to take away that they can think about when they're thinking about a patient to treat or how to present it. Give me your best clinical pearl for Sprint.
I
Tracy.
think for me, I think it's just knowing that it's not permanent, right? It's not permanent, but it's effective. And I think that why wouldn't you? In the right clinical hands of a individual that knows how to put this device in, and you got the right patient, why not give it a try?
Awesome. Jennifer.
Yeah, so for me, if you're seeing a patient in your practice and they've tried everything and it's been a while since they've had a consultation with an interventional pain physician, this may be something that they haven't tried. Send them, let us talk them through it. And if it's not right for them, then we can send them back. But like this lady, that my favorite lady, she spent years trying to get this fixed, better pain relief, and she was able to get it with us because we were trying new treatments, new interventions. So send us the patients. We'll take care of them.
Mhm.
All right, Victoria, give me your pearl.
I think talk about it early and often. Sometimes with neuromodulation, people get really uncomfortable when you start talking about sticking wires in people and stuff like that. The more times you bring it up, the less hesitant they may be over time. And I think the other thing that I like to talk about with people is it's so minimally invasive. In higher risk patients where maybe something like a DRG or spinal cord stimulator might not work well because they have to hold their anticoagulants for a longer period of time. This may be an alternative to that. So for those patients who might lose out on some therapy, you might find that this device is an option for them. So health status isn't always a barrier to some degree. It might actually you might be able to use this as a tool for some of those patients.
I love it, guys. These were awesome tips. Thank you so much. Thank you everyone who joined us this evening. I really, really appreciate everybody's time and dedication. And honestly, you guys did an amazing job presenting this. And I think, like you all said, the data, it's really impressive. I don't understand, Tracy, rather, how anybody would actually say no, right? If you're at a point where you're like, I've tried everything, this is a great option. So thank you all for coming on and sharing your pearls of wisdom with us tonight. And thank you to Sprint for sponsoring this webinar with PSPS. And thank you to everyone who participates in our APP courses. And we look forward to hopefully seeing you guys at the mid-year lab and APP course. And if you have any questions or you'd like to get involved, please don't hesitate to reach out to myself or any of the panelists. So thank you so much and have a great night.